You're listening to the Turn Autism Around podcast, episode number 158. Today, I have Dr. Steve Hodges, who is a pediatric urologist, talking all about constipation, potty training, bedwetting, and daytime accidents. And he is a wealth of information. I've been following Dr. Hodges for well over a decade, and he is an associate professor of pediatric urology at Wake Forest University's School of Medicine. He is a real expert on all of these topics with books, and he has a clinic in North Carolina, as well as a few Facebook groups. We talk all about the challenges with potty training, the challenges with treating constipation, and specifically with kids, teens, and adults with autism. We even talk about the signs of constipation and issues with babies. And we talk all about how to treat them right here in this episode. So let's get to this episode with Dr. Steve Hodges. So Dr. Hodges, it is so great to finally get you on the show to talk about potty training and constipation, and all kinds of potty problems that the parents and professionals in our autism field deal with. So thank you so much for your time today.
Thanks for having me. We're really excited to talk about the subject, which I think is kind of not discussed enough.
It's not. And I have done a lot of work on potty training as a registered nurse and a board certified behavior analyst and a mom. And so in my first book, The Verbal Behavior Approach, there's a chapter in here, and there's a chapter on potty also in my new book, Turn Autism Around. And I have a free potty guide, which is like 25 pages that we can link in the show notes as well. You can get that for free. So I have been developing my expertise over the years. I was always a neurologic nurse, so I dealt with a lot of incontinence and that sort of thing. So it came naturally to me to deal with this subject, which is really tough. But you are a pediatric urologist. And so how did you fall into the world of basically being a doctor that deals with constipation?
Yeah, that's a good question. So we deal with two basic things. We deal with like congenital anomalies of the, urinary tract or genitalia. And then we deal with peeing problems in kids. And so that includes daytime wetting, nighttime wetting, UTIs, and so forth. And a lot of those issues are actually caused by constipation, and it almost becomes a cliche, like, it's just that. But honestly, it's a significant factor. Now, most urologists in the country don't see patients that are non-surgical. They'll see, the surgical patients, and then if there is a child with what we call dysfunctional elimination or bowel and bladder dysfunction, we'll go to a kind of a physician extender, maybe nurse practitioner, PA, and they'll run the traditional cookbook protocol for those treatments. I was in a setting where that was not available, so they were all seeing me, and I was running the cookbook protocols, and I was getting poor results. And so
cookbook being like prune juice, increase your water, wake them up at night.
Yeah, it's basically everyone knew poop was an issue, so everyone gets Miralax, they get time voiding, and they get maybe some medications. Like there's some medications we have that can relax the bladder. They don't really work that well and get into that in these kids. And so that was it, and you'd come back and they would, just rinse and repeat. And I was getting frustrated as to why, I don't like being in a clinic. They come back with the same problem and I have nothing to offer them. It's frustrating for me and the parents. So I feel like I've told this story so many times, and I don't want to bore anybody, but it's an interesting story. So what happened was that I had a kid that was had kidney reflux. You may be familiar with that. So she was having a lot of kidney infections, bladder infections. And kidney reflux, you can be born with it, but it can be made worse or persist, or you can have more infections if you're constipated. So one of the things to do is to fix that. And a lot of girls that wet the bed also have UTI. It's all related to the poop. is a nice girl from a nice family. Well, they were doing everything they needed to do with the Miralax and the time voiding, but she did not progress, and so she needed surgery for a condition. So she moved on to surgical options. When I did the surgery, I had a difficult time because there was large massive poop in her rectum. So like it made the floor of the bladder abnormal, kind of was pushed up and angulated in a way. And I was like, geez, this kid's not pooping well. And I went and talked to the family afterwards. I said, you guys been doing the program? Like, yeah, she's pooping every day, doing great on Miralax. I'm like, we're missing something here, significant. And the next week, as fate would have it, I went to a meeting in Cincinnati Children's Hospital about congenital anal rectal anomalies, because we deal with some of that as well in conjunction with the general surgeons. And they were showing me their bowel program as part of the course and saying, look, we get x-rays on everybody. Empty. And I was like, you know what, I'm going to start getting x-rays, because obviously asking the parents wasn't working. I remember that first clinic. I remember like it was yesterday. I had a first kid showed up, bedwetter. I asked, are you pooping normally? They say he's pooping fine. I get an x-ray, just so much poop, just a dense, massive poop in the rectum.
And this is just a regular standard x-ray that shows
plain
that.
KUB x-ray, flat plate, and treated that, not the symptoms. How are you pooping? Because most people were giving you Miralax until you poop daily. This kid was already pooping daily. I treated him until I got the mask on. Was dry, and I started curing people left and right. I was curing my neighbors.
You treated him for what? You treated him until his...
for that actual mass. Like, so my endpoint wasn't
okay.
My endpoint was a clean x-ray. You follow
Okay.
me? And so he did great. And I started just treating lots of kids. I was treating neighbors' kids from church. Just, hey, take Miralax, do this, do that. And the kids with no signs of constipation, I was helping them out with the bowel program. So I thought this was novel finding. I was going to write this up and win a Nobel Prize or whatever. And I found out that this had been written about in the 80s by Dr. Sean O'Regan. He had written that bedwetting, plus a lot of other these related issues, is due to occult constipation. You give them enemas every night and they get better. And I don't know what happened. People just don't like enemas. They stopped using them. They went to Miralax. Their end goals changed, and kids were getting undertreated. So we spent the past 15 years, I guess, now trying to spread the word.
Yeah. Wow. And I remember somebody recommending your book, It's No Accident, which I think was written in 2011 or 2012. And I did a lecture on potty training. It was sold for many years. And so somebody gave me this book or recommended it soon after that was published, because I didn't know. I mean, I knew that constipation could lead to bedwetting and that sort of thing, but really this book was so much new information. I mean, it's like highlighted, cornered. In fact, it's been so good that it really has been one of the staples that I tell people about. It's in my 2021 book, but I didn't realize that you have a lot more information that's more updated in your pre-MOP and your MOP book, MOP. So MOP stands for what?
So remember in the It's No Accident book, the doctor that we found that had started this was called Sean O'Regan, Dr. O'Regan, and his protocol we called it the O'Regan protocol. And through experience and our casework, we've modified that. So MOP is the modified O'Regan protocol.
Modified O'Regan protocol. And in your It's No Accident book, there is some things about enemas, but it is a lot of Miralax. And in fact, in my 2021 book, when I referenced it, I said a lot of the parents that I work with kids on the spectrum are leery about all this Miralax, that it, a lot of people think that it's not good for you and that sort of thing. So in your newest books, you do talk a lot about other options for laxatives, and you do talk much more heavily about suppositories and enemas, which you say in your books, people are like, that's really extreme. And as a registered nurse in the 80s and 90s, I remember actually giving enemas, and the thought of giving enemas to a toddler or an older child or a teen does sound extreme. So how do you respond to that?
Yeah, so I'm definitely open-minded about it. If the child has been on no therapy before, then Miralax is a good first step. With the other laxatives, it doesn't really. I just want the colon empty. You could come up with a new way, and I would be all for it if it worked. But we have a lot of kids with encopresis, which is poop accidents from overflow, or they can't get on the right dose of Miralax because they'll give some and nothing changes, and they give a little more and they get diarrhea. And that's all. Both those situations there's a big clog at the end, and so just getting to the root of the problem. Enemas are much better at getting to the root, and I love how Dr. Regan is just a pure scientist when he started this, and we surgeons, I guess doctors tend to be pretty analytical, algorithmical. So he was like, well, the problem is the poop in the end of the rectum. The best way to get there is with an enema. So that's the solution. You probably remember this from the book. He treated his own son first. It wasn't like he was putting this to other people. So yeah, it's just the shortest route to the cause of the problem. So most people do fine with them. But we've tried to adapt the protocol to give options that any family can follow, whether they want to avoid Miralax or use Miralax, or avoid enemas or use enemas. We can find a protocol to get the child empty.
Okay. So since we're mostly speaking to parents and professionals in the autism world, I know firsthand that constipation, bedwetting, failure to potty train, poop accidents, those are huge issues. I've done podcasts and blogs. You're my first expert to have on, so I really appreciate your time. And I do also want to say, since Dr. Hodges is a medical doctor and I'm a registered nurse and a behavior analyst, that everything that we're presenting here is for informational purposes only. And you really should work with the information in his book, and he also has some Facebook groups we can talk about and we can link in the show notes. But you need to spread the word to your physicians and your healthcare providers to really get you on a plan. Also, as a behavior analyst, I know there's a whole lot more that goes into potty training than just treating constipation, and kids on the spectrum can have major problem behaviors and all of that stuff too. You also, before we really dive into like constipation in babies and constipation in older kids and how to treat it specifically, I did just show Dr. Hodges before we hit record this small pamphlet. Is called The Fatal Four, and it's by the Pennsylvania Department of Human Resources. So since Lucas is 25 years of age at the time of this recording, everybody that works with Lucas through his waiver has to read the Fatal Four. And basically, these are 4 conditions that can lead to death and are the 4 most common causes of death in adults with developmental disabilities, including autism. And they are aspiration, which is choking, like, eating food and then going into your lungs, and you could die from that. Constipation is the second, dehydration, and seizures is the 4th. But this is a big issue in the autism world. One really, even for a child or adult who is fully potty trained, like my son Lucas is, he can't tell us if he went, what the consistency of it is, if his belly hurts. He might say belly hurts, but that would be very late in the game. And so for kids that are fully potty trained, that presents its own unique challenges because you can't easily keep an eye on things.
Mm-hmm.
So let's go way back so I just want to emphasize how serious constipation is, and that it's not just annoying bedwetting and changing the sheets, which is very time consuming and causes a lot of stress to families, but it also can be deadly and lead to really very complicated situations. So let's go way back to like, why is constipation increasing, and when does it start in babies, and what should we be looking for? Because we go the whole age range here.
Yeah, I think it's probably always been prevalent. I think we're probably doing a better job picking it up now. My theory is that it obviously diet and activity, exercise can influence it, but honestly, that the human brain is just too smart for its own good. There's no other animal or mammal that's going to purposely withhold poop. They just go. But humans, if it feels uncomfortable and they can figure out that if they squeeze their sphincter and put it off, it goes away. There you go. That's as easy as it's as simple as it is. And definitely runs in families or genetic traits, like whether it be personality traits, the whole concept of being anal retentive, whatever it is. Some people are just more likely to withhold than other people. And you see this right away. When babies are born, the poop is very mushy. It's, they're just on breast milk or formula. It comes out like mustard seeds, you probably remember. But even then, there's some discomfort. It's the sensation of having to poop, out of the womb. You're not pooping in there. And then all of a sudden you're having this weird sensation, so they don't relax. It's called Dyskeysia. And it's a transitory phase where they get through it and they start pooping normally. And typically, then you'll see babies in this kind of nice in-between zone where they're pooping in diapers without even, you hear it, you can't tell from their expressions that they're doing it.
So when does this little phase go when they start doing something different? Like
if dyskeysia starts, it starts at birth, and then usually after the first couple of weeks, it's gone. Okay. And that's the kids that used to tell you to, put some Vaseline on their bum or use a thermometer to kind of force it out. Remember, my oldest had it, and I was like, "What's she straining for?" And I went to put the thermometer down there, and it just liquid came out. There was nothing actually constipating there. And after she got used to going, it was fine, and she didn't have any issues. But then, you have other things, and that typically is change in diet. So if you go to a different formula or a different feed, adding rice cereal, something like that can do it. Did one of my kids, adding table food for sure, dairy for sure, just change the consistency. And think about it, right? You feel something different, you start holding, and that's all, and it snowballs. And then sometimes not only is it getting firmer poop, but it's getting looser poop and then going back to normal. So an antibiotic treatment, which gives them diarrhea, they feel discomfort from that. And then once the poop firms up, it starts it. So any kind of phase like that makes them uncomfortable pooping can be all it is, all the trigger you need to start this kind of cycle of constipation. And a couple of things on that topic I think are important. Number one is once it starts and they're prone to it, you need to keep an eye on it, because it's not like a weak phase. It's not like you're going to give them Miralax for a couple of days and they're fixed. It's in their head now, and they need to be going regularly for a while. And the second thing is that it's a chronic therapy. It's some kids that are very prone to constipation. Parents will give them Miralax, get them through the phase. And then when they stop it, they worry, like, are they addicted to the Miralax, or why can't they poop on their own? And it's just that this child has now learned that it hurts to poop. And so they need extra help, and keeping it soft so that it doesn't hurt them is all they need. But they may need that help for years until they're old enough to know that when I need to poop, I need to let it out. And it could be, some people never get there, but it could be a few years.
Yeah. So in both your books, and I haven't finished them both, but I get the idea that you believe that everybody, every child and adult with or without autism, should be pooping every day.
Yeah, I definitely think that if you're eating every day, you should be pooping every day, and that's pretty consistent along the animal world. So every time I make a claim like that, I kind of regret it a little bit later, because I have parents really going all out to get a kid to poop every day, and maybe if they pooped every other day, they would be fine, So I think pooping every day is a good goal. But really, the child has to have a sign that they need help to be really aggressive with it. Belly pain, hard bowel movements, accidents. If the child's completely healthy, just living life, doing great, no issues, pooping every other day is not a big deal. But you definitely want to keep an eye on things and be aware. I think going from being aggressive with them pooping too much, and the opposite, where you don't even know how often your kid poops, there's some kind of happy medium in there where you're just keeping an eye on things and making sure things are regular.
Yeah. So changes in diet, being on antibiotics, having, diarrhea and then firming up, those can all be kind of critical junctures where a child could start to get constipated. And it's just not normal for constipation to occur. I remember, people I knew were like, oh, my kid poops and not on the spectrum. He only poops every 7 to 9 days.
It's insane. Yeah, I think it's the most common medical condition in children, functional constipation by
Right.
far.
So if I had a, say, 5-year-old potty trained child, or even a baby, because this was a baby not going for 7 days. So if I have a baby that hasn't pooped for 7 days, what should I do? Should I go to my pediatrician? Should I ask for an x-ray? Should I try to clean them out myself, or depends?
Yeah, for the infants, it's tough. And I'll say why. It's that there's this thought, and I honestly have not pinned them down on this, but there's a thought amongst pediatricians that if you're breastfed, right, if you have this pure diet of breast food, then you're not making enough poop to poop but once a week, and that's a study that needs to be done, right? Maybe like ultrasound their rectum and see if it fills up or they're not going. So again, I'm a big proponent of aggressive treatment of constipation, but I have to have a cause, because I don't want to be just tracking kids down the street saying, you need Miralax. So in the babies, if they're otherwise completely healthy, no other issues, and they're on breast milk, talk to your pediatrician. If they think it's okay and you're happy with that, then it's fine to kind of slow roll it. But if you're having a child that is straining to poop, having large bowel movements, definitely having difficulty, like pooping is in their brain, it's a stressful situation for them. Hiding to poop is a big one. People think they're just hiding because they're shy. It's a sign of constipation. Then I would definitely talk to your pediatrician about getting a treatment for that. And I think, most kids go through a phase like that if you think back to it. And just keep track of, be involved. You're involved in your kids' diet and their exercise and all that. Be involved in their toilet habits as well. Take a look and see. I know it sounds weird, but it's really important. If they're putting out, the most common sign we hear from parents that we know to be constipation, the parents just mention in passing, is, oh, he does the biggest bowel movements. They're just huge, And so that's a bad sign. And I know I say I don't want to treat things unless the child is having problems, and I definitely believe that. But if you have a child that's severely constipated, they may develop issues, right? So you don't want to completely be out to lunch if they're having some signs just because they're happy and healthy. You want to keep tabs on things, because they could develop some issues later on. And I don't think it's healthy to have a hugely dilated full colon, period, just for adulthood and so forth. So I think awareness is the key. We can figure out the details by talking to your pediatrician. But if you have a child that's having trouble pooping, they don't have to. And if they're having other accidents or other issues, we can definitely fix those.
And in your books, you do say that potty training, or really heavily focusing on potty too young, can also be a critical junction point for kids to withhold and get constipated.
Exactly. I got a little sideways with a lot of the elimination communication people, just because they really promote, and I'm not for pollution like diapers. I know create fill up the landfills, but I think it's definitely unhealthy to train too early. And you have to look at what are we doing. People that try to get out of diapers too soon are probably just training themselves to respond to the child's urges and signs. The potty training, and this was from Dr. O'Regan, a quote he told me, and I think this is 100% accurate. It's a physiological process, like walking or sleeping or being hungry and eating. You can't force any of this, right? You can't make your child sleep. You can put them in the right environment. You can't make them crawl or walk any faster than they were going to. And you can't make a child potty training any faster than they were going to, although it can be delayed if they're constipated because they lose control. So I have not seen a child younger than 3 that's really ready, and I haven't seen many kids older than 4 that shouldn't be ready. So for me, between the age of 3 and 4, if they're developing normally and have no other conditions, obviously, then that's a good age to potty train.
Yeah, and I do want to make a caveat there, because most of the kids that the listeners are either their own child or their clients, they are developmentally delayed, and that adds a whole nother twist to it. And so from a behavioral point of view, I am all about tearing up the potty early, like at 2, just to make it part of the, oh, we sit on the potty. We don't even have to go. We just sit on the potty in the morning and maybe before bath, and we watch their older brother. And I'm also a huge proponent on boys should sit on the potty until they're fully bowel trained, because I hear it all the time. An older boy is pee trained, but not poop trained. And almost always I'm like, are they sitting on the toilet to pee? And they say no. And so, in one of your books, you talk about like scheduled sits right after breakfast or right after dinner when you are more likely to poop, or first thing in the morning. Physiologically, you're more likely to poop. But I do think that for kids with autism, waiting too long to introduce the potty, as this is where we sit just to relax, is also a problem, because then they might be super resistant on top of it.
That's an excellent point. There's no harm in introducing things. You don't want to pressure them to hold it in. That's the thing. Number 2, the one downside of delayed potty training or later potty training is that some kids just get too comfortable pooping in pull-ups, and toilet avoidance for pooping is super common. So typically the kids will pee on the potty and then they won't poop, or they'll, the story of the child that will just be completely dry but come home and ask for a diaper to poop in or pull up is so common. I have seen, and there's protocol set up to treat that issue.
And how do you treat that issue?
There are 2 ways to treat toilet avoidance. One is with this, it's in the book called The Ins and Outs of Poop. It's kind of this graduated just kind of movement towards the potty.
I actually have that book right here.
Yeah, there you go.
I have my whole potty training collection.
Yeah, and it's I've given it to a lot of families. It works well. Basically, you say, okay, you can poop in the pull-up, but you have to poop in the bathroom. Okay, you can poop in the pull-up, but you have to poop on the toilet, that kind of thing. And I love the story he has of the girl that will poop on the toilet, but she has to put the diaper on first because they had cut a hole in the diaper, and she hadn't pooped anywhere near the diaper in so long they just kept the same one, and so it was like a belt. She was like much older, but she needed that, and so it just shows you how much thought people put into this kind of thing.
And I have
another approach
where you can have the diaper, but you have to stay in the bathroom, and that gradual fading of the diaper does tend to work. However, I will also say, especially after reading your new information, is that the child's probably constipated if they're able to hold it all day and ask for a diaper. And
they're not going on time, right?
And they probably could also benefit from laxatives and enemas, which is tough, because if you can't even get a child to sit on the toilet easily. So I have a lot of advice about pairing and desensitization. But if you can't get them to do that, how are you going to be able to have them calm and comfortable enough for you to insert something into their rectum?
Yeah, the other approach which gets to that point is the Dom approach. I know Dr. Dom that recently passed this past year had an approach for encopresis. And so if you need to force the issue, for example, like if you have a kid that's just too comfortable pooping in the pull-up, it just has no interest and just not going to go anywhere with the pull-up. He has this protocol that was originally designed for encopresis treatment, but he basically has the space that the child can move in confined. So typically you're in a bathroom, has no bottoms on, so the child doesn't have any kind of perceived protection, because for whatever reason kids will poop in underwear before they'll poop on the floor. Some kids might poop on the floor, but there's a barrier there. There's extra barrier, mental barrier. And then he gives them a really high dose of X-Lax. His dose was 6 X-Lax squares. And so then it becomes like this kind of standoff. So these kids that are like, would never poop in the potty ever. They've been exposed to the potty, like you talked about. They know what it is. They just don't like pooping there. They're given this X-Lax. They have no underwear on. They're right next to the toilet, and all of a sudden the urge hits them. And they do sit on the potty typically at that point, because it's like you have to decide. It's coming on, and the brain knows immediately that there's no stopping it. And so they tend to poop on the potty. And that's just kind of like the sink or swim method that sounds extreme, but I've seen it work in certain cases very well.
Mm. Yeah. And even in, I mean, my first book, I mentioned this Richard Fox book. Richard Fox is a pretty famous behavior analyst, and it's called Toilet Training in Less Than a Day. And it was written in the 70s, early 70s. So there's actually a punishment procedure in here that once they have an accident, you take them to and from the accident. Unfortunately, unfortunately, I, you know, a lot of behavior analysts still kind of subscribe to some of these methods. And even in my first book, I do talk about how we did use positive practice, which is a punishment procedure, which I do not recommend. We used it to get Lucas poop trained. After I literally called Richard Fox on the phone and asked him. Now, you know, 15 years later, since writing that book, I am all about a positive approach and all about treating the medical underlying condition, especially constipation and other weird things that could be happening, and to never punish or stigmatize a kid, or so we want to be as gentle, as positive as possible. But at the same time, we do need to treat these kids in some way, because potty accidents, I mean, you've said it a couple times, and encopresis is poop accidents, and enuresis is pee accidents, and it can be daytime or nighttime. It's extremely stressful for the child and the family.
That's a great point. So you do not want to punish the child. This is a very common cause of abuse. It's frustrating for parents that aren't informed. They think the child's doing it on purpose or just not being responsible, and so it causes a lot of abuse. So we don't want that. But the alternative is not ideal either, just ignoring it, because it could be as simple as constipation, or it could be a real medical condition. They could have a spinal cord disorder. They could have a congenital anomaly. So you need to have it evaluated and treated. And if it's just constipation, hooray, we can work through that. But you don't want to ignore it, because it could be some other issues. And yes, the quality of life effects of these problems on children are significant. They've been published extensively.
Yeah. And this fatal 4, I mean, constipation can actually be so serious that it leads to obstruction, needing surgery, and death.
And you don't want to get to that point. Exactly. And there's usually warning signs that we can talk about. And the autistic kids, I think, and I'm sure we're going to get into this, is that they a lot of these problems are ignored because they're blamed on the autism. Well, you know, they're not potty trained yet, they're just developmentally delayed, or they just can't do that. In reality, much like in kids with ADHD, there's a high rate of constipation, which then manifests itself as these accidents.
Yeah, and one of the things, and I mean, Dr. Richard Fox is a brilliant man, and I mean, he was doing research in the 70s, so it does have, you know, some punishment and things we did that now are not acceptable. But you know, he was a big proponent of any child by the age of 5 at any cognitive ability level can and should be potty trained.
I agree with that. Yeah.
And I agree with that too. And so when I hear of older children, teens, or even adults who are not potty trained, and it's not that the parents and the professionals haven't really tried, but I do agree that just talking about constipation, not just talking about it, like x-rays, Miralax or other laxatives, enemas or suppositories, like it's not enough to go, well, we have tried, we've done this or that, or we try to take him to the bathroom, you know, every hour on the hour. It's like, well, if that's not, you said something in one of your books, like, if any part of this is definitely not working, you don't want to just keep doing it.
Yeah, 100%. If they're behind the 8 ball already because they have no control of their bowel or bladder or both because of constipation, any kind of behavioral therapy is going to fail. And you know, a lot of these things are appealing to the mind. Like, okay, well, they're not they're having this potty dance or having accents. They're waiting too long to go pee. And so I'm going to have them pee every hour or every 2 hours or every 30 minutes. And if I wish that worked, but what ends up happening is the kids sit in there, they don't have to pee, they get up and have an accident. And one thing that really had an impression on me is in some severe cases, we will do Botox because it can really limit the effects of the colon on the bladder or block them. So the bladder is not overactive, independent of the poop, kind of makes the bladder ignore the signals from the
So
poop.
wait, so what do you do with Botox? You
You can inject it in the bladder.
in the bladder, okay,
Yep.
to prevent pee accidents, even if they're related to constipation?
Because the reason the accidents are happening is because the dilation of the rectum is causing a nerve firing that's setting off the voiding, and that will block that signal. It's kind of this, this kind of how much signal, how much blockage you have kind of thing. And so in severe cases, I mean, I always work on the bowels, but that's that kind of last resort. It's expensive and it doesn't last, so it's not like a perfect thing, but it can help some kids. But the reason I mentioned is there's an anecdote. I had a kid that was, these parents were like, this kid will not go to the bathroom. He will not go to the bathroom. He will not go pee. We talked to him. We've tried everything. We've tried bribes. We've tried everything. He will not pee. We did the Botox. That kid, he had a good dose. It kind of, it took with the right dosing, right? Because there are a lot of variables. The next week, he was peeing completely normally with zero behavioral changes. So what I've understood is that the urge to pee, like, it's not like you or I have some special gift because we can go pee when we need to. Our brain tells us we need to go pee. But if your brain tells you got to pee and then it fires off to 100 too late, then you can't make it. So I always tell parents that if you had your child's bladder, you would have accidents, And if we fix the bladder, he couldn't hold long enough because you wouldn't be able to hold too long because eventually you're forced to go pee, much like potty training is a physiologic process. Going to pee on time is a physiologic process. So if you or I right now tried to hold our pee till we had an accident, our brain wouldn't let us. It would make us go to the bathroom eventually because it just becomes annoying. And so that's it. There's some delaying and emptying, of course, because they hold their poop in. But if a child's sitting there and pees on themselves or poops on themselves and didn't even know it, there's more to it than not going to the bathroom.
Yeah. So you talk a little bit, and I talk a little bit in my stuff about the policies of daycares and preschools of, peeing by 3, potty trained by 3, no accidents or a couple of accidents for a set amount of period. Otherwise, you get held back, kicked out, not promoted to the next class. I even had a client who had to pay a premium to kind of have her daughter go to the next class, but then have more support there in case she had to pee. So, and even schools, kindergartens, first grades, they have very restricted, like, punishing kids for needing to go to the bathroom. So can you just talk for a minute about that?
Yeah, I try to take into consideration everyone's perspective here, because I'm not running a school or a daycare, and I figure it's difficult, but as long as they have the understanding. So I don't want the daycares or schools to think the parents are being lazy and just showing up, here's a kid that doesn't know how to potty train. Again, as we talked about, if the child's old enough, they will pretty much potty train themselves if they had the exposure to it, like that you talked about. So if they're not potty trained, there's a problem. And so number one point is I'd like to pick this stuff up early so no one would have to deal with it. We could just treat these kids very early before they got there. But I do think if a parent's forcing a child to potty train before they're ready, before they're 3, and the child obviously doesn't have the maturity, just to get into daycare, that's a bad thing because you're forcing a process. And again, it's a process we just mentioned several times you can't force. So I try to help parents get notes or doctor's support to allow the child to go at their own pace. Schools, another thing, I know they need to keep track of the kids. School safety is a big deal. But I think there's definitely ways that you can develop systems that keep track of the kids, minimizes, I don't know, kind of running around the halls, but allows them to go to the bathroom whenever they want. And the behavior that we've heard of, I'm not saying kids should have free reign and just run around the bathroom whenever they want, but to have them run laps or pay money or whatever to get access to the bathroom, which we've seen reported, is beyond the pale. So I think we can all get together, and if we understand that, look, kids train at their own rate. It's a physiologic process when they're ready. And if they are having accidents, they have a medical condition, and holding in their pee and poop especially poop, which no one likes to do in public, can lead to problems. And I think we'd get everybody on board and come up with plans that would help these kids get access. I was just talking to a pediatrician today. I wish we had, private restrooms everywhere, right? Like in schools, like most kindergarten classes have them, but beyond that, they don't. Because there's so much of a barrier for kids to poop in public. It's tough.
Yeah. And one other thing that before we leave the school is also once a child with autism is toilet trained and is spontaneously asking to go to the bathroom, it's really important that we don't put them on a schedule. So I was always very big proponent of, when Lucas would switch teachers or go to a new grade or go to a camp or something, like, I don't want him going every 2 hours or every hour and a half with the class. I want him to request, because you can get a kid that's potty trained and spontaneously asking to revert back to having accidents because they're put on a schedule. So also something to keep in mind, especially for kids that are new to toilet training and new to asking, which is a hard thing for a lot of kids.
Mm-hmm.
So I assuming, and it's in your books, that keeping an eye on your child's poops, and having school home communication about pooping and peeing is really an important thing.
Yeah, I would, a part of open house, I would check the bathrooms out. Where are they? What do they look like? What's the bathroom policy? Are they clean? Do the doors work? Is there toilet paper? These are important things, because if your kid shows up there and doesn't feel comfortable going, then you could potentially have some problems.
And you also have in one of your books a letter to use to kind of be like, my child has some constipation issues and they need to be given
free access. Yeah.
Yeah.
I write a lot of those letters. Yeah, I write a ton of those letters. It's important, and I think, some of it's restriction, some of it's kids aren't comfortable doing it. So I think as a society, we just need to talk about this more and pick up the importance that, we talk so much about, you need to exercise, you need to eat right, you need to do all this. So you need to brush your teeth, you need to floss. No one ever says you got to poop when you feel it. It's just kind of ignored.
Yeah. Yeah. So with both of the pre-mop book and then the pre-mop book is just for kids until they're potty trained. Babies.
Yeah, that's the pre-potty training constipation. Yes, ma'am.
Okay. So even if you have a child who's older with autism, chronologically, they're developmentally up there until they're fully potty trained, right?
Yeah, and if I'm going to hedge that a little bit, because if you have like a 10-year-old that wasn't potty trained, you're probably going to need to be aggressive. So it might be better to do full mop, because I would say, okay, should definitely be potty trained. So since we're so far past it, let's treat this as accents, not as never potty training. Does that make sense? Yeah.
Okay. So there's two books, the pre-mop book, and that is for kids that are babies up until they're potty trained, except for if you have an older child, like if you have a 5 or 6 year old that's never been potty trained,
you just want to regulate their pooping to potty train them. Exactly.
And then an older child or teen, or
and that's kids that are having accents. Yep. And we actually have a book out for teens now too.
Okay.
Yep. Just to make them feel a little bit tailored to them, because I know that sometimes they don't got on the Facebook page, they express they didn't like being clumped in with the younger kids. Yeah.
Yeah. And we're going to talk about the Facebook groups in a second. And in the pre-mop book, you do say that young children, babies you could use suppositories instead of enemas.
Yeah. So there's a liquid glycerin suppository made by Pediatrics for ages 2 to 5. But you can take little slivers. You can talk to your pediatrician about it. You can take the solid glycerin suppositories, get a little sliver of it and put it in there. Just a little stimulant to get things going. Okay. Especially if they're trying to get out a large kind of lead fragment, we call it in urology, a big mass that's blocking everything. You just got to get it out there. And there's lots of things you can do. You can use Vaseline as lubrication. Some kids are put in a warm tub with baking soda just to relax the muscles to get past that kind of stuck part. And this is just like a question I have, because like I said, in the 80s gave enemas, so I really don't know how to do that now. But, do they sit on the toilet while you insert that? Is it
do they lay on the bed and lay there for a while and then go? Like, how does that work, like logistically?
Yeah, the best way to do it that we taught, just kind of keep it simple, is have them lay on their left side, because the sigmoid goes down that way, and put the enema in. So they're on the floor in the bathroom, kind of. I mean, you could do it anywhere, but I don't want to be responsible for messed up carpets, so I say next to the toilet.
Or
And
like
so you,
put a waterproof thing down on the bed.
yeah, you're probably not going to have something come right away, but
Okay.
you have time. It's just the first one, maybe just do closer. You put it in and you just tell them to hold it till they have to poop, and typically the kid will get up and be like, "Oh, I gotta go," and sit in the toilet and poop. It's pretty immediate. Yeah.
Okay. All right.
Plenty of lube. That's the key.
Yeah. Okay. So, I mean, obviously that's for some child that's going to tolerate that, which, is probably a little farther down the line than for most typically developing children who can understand that. But at the same time, I do know families with kids that aren't constipated that do clean them out with enemas and suppositories and laxatives, but they only clean them out, once a week or once a month.
Mm-hmm.
And so this would probably be, an adjustment for sure and a new protocol, but it's not like out of the question. Like if you have a child that doesn't poop, that's constipated, you're going to need to do something to get the poop out. And I like the idea of talking to your pediatrician potentially about getting an x-ray, just so you and the child and the pediatrician all know that this is a blockage. This is a lot. And because I remember in your first book, and maybe I don't have the statistics right, but like you had people coming to your clinic in North Carolina and 90% of the parents said their child was not constipated and 100% of them were.
Yeah. The only reason I get x-rays anymore, other than to monitor progress, is to get the family on board, because I'm already, I know what's going on, and it is effective in doing that, because when they see all the poop, they're really aggressive. And I think a couple of points on enemas. Number one is you never know how they're going to react till you try it, so you can try it and use our techniques. Second, if you think of this as a medical condition, I think it changes the analysis a little bit. Like if I, God forbid, if one of my children had some severe medical problem, but I had a cure, but that cure was an enema, I would definitely do it, So I think because people outgrow accidents, or accidents aren't really seen as a medical condition, it becomes a little more difficult. But if your child had, pick a horrible disease that would be cured with an enema, I'm sure parents would do it.
Yeah. And for very young children, then you could do a suppository. You could even probably do that with them on the toilet or bending over or something.
On your lap is easy.
Yeah. On your lap. And
then put them over kind of like that,
Yeah. Kind of
bum up. Yeah, exactly.
And I mean, we've done suppositories when we've had babies that have had fevers and that sort of thing. I like your idea of like, think of this like a medical problem. Think of this as something you have to solve, because something I read in your book is that if a 9-year-old is having bedwetting and constipation, the chances of them being, a teenager with constipation and bedwetting is very, very high.
Yeah. And you don't want to be stuck as that's what happens. They're waiting to outgrow it. Next thing you know, 10, 15 years go by, and then, they're getting ready for college, and it's just, and then I can't promise that this does or doesn't happen, but there's something to be said. If your colon is dilated abnormally for years, that's definitely worse than if it was dilated for a shorter time, So 15 years of dilation is more difficult to resolve than just 5 years or 3 years. Yeah. And that makes sense.
And in the autism population, the older your child gets, the bigger they get, the more aggression can happen, the more physically, the earlier we can get to this, the better. And like I say with ABA, it's never too early and it's never too late. So whether you're listening and you don't even have autism in your world, we really have talked very little about autism. Well, I've talked, but it does complicate things. But at the same time, it's the same techniques will work.
Yeah. My synopsis, like the main thing I want your viewers to get is that these issues, so whether bedwetting, day wetting, poop accidents, delayed potty training, are all written off as part of autism. Oh, it's an autistic child. they'll train later. And so we have more cases of missed constipation. So I have more cases of missed constipation in autistic children and more cases of severe constipation in autistic children. So I would say that the same rules apply to them as that would apply to any other child. If they can't potty train, if they're having accents, get the x-ray. The x-ray will likely show them full, or get evaluated by a doctor. Maybe they'll find something else. But if they find the constipation, you follow our protocols and they should do great.
Right.
Yeah.
And you have a clinic in North Carolina.
Mm-hmm.
I don't know, do you accept kids with autism, or does they?
Oh yeah, they just come because they have these issues, and they need help.
Yeah.
And
yeah, I'm sure you would want people to try the method that's very well outlined in your pre-mop and mop book. And then you also have you have 3 different Facebook groups that are paid Facebook groups for parents or professionals to join. Is that right?
Yeah, so we have a parents only book that's page that's free. We have a just generalized informational page that's free. And then for the paid group, we have a teen group because they, again, they wanted their own group, the traditional mop group, and then the pre-mop group. And I'm just coming off a busy weekend. I have to check it today, I think, to catch up. But the, I think it provides privacy. It provides kind of a, I'm not the only one in this kind of mess feeling, and advice from other parents. As a scientist, I'm used to doing studies and kind of collecting data over time, but the internet's pretty amazing. I mean, we've learned so much just from the real-time feedback from the parents, and modified our protocol quite a bit just from their feedback.
Yeah,
very useful.
Which is awesome. And the website is
bedweddingandaccidents.com.
bedweddingandaccidents.com. We'll link that in the show notes as well. And it's been a fascinating interview for me. I have followed your work for over a decade, so I am really excited to get you. I'm sure you are going to definitely be an episode where I'm constantly giving out the episode number. So thank you so much for your time. Before I let you go, I always like to end my podcast the same way. I didn't warn you with this, but as a very busy medical doctor, as a father of 3 girls, part of my podcast goals are for parents and professionals to be less stressed and lead happier lives. So do you have any stress reduction tips for everybody listening, or self-care tools that you can recommend?
Yeah, self-care. I think getting plenty of sleep, the basics, eating right, exercising, the gym, and then it's so funny. My wife jokes like you become so much more religious. I think family stress is just like, I'm like, oh, you need somebody else to kind of lean on. And so I'm a Orthodox Christian, and that just the teachings have helped me a lot. And so I hope that I can be a better father and husband using those techniques.
Awesome. All right. Well, thank you so much for your time, and take care.
Thank you so much.